Welcome to the Impact Education PayerTalkCE program entitled Understanding T2 Inflammation, Best Practices in COPD Management. My name is Jeff Dunn. I'm a pharmacist. I am president of Cooperative Benefits Group, and I will be moderating today's program. This PayerTalkCE program is jointly provided by Partners for Advancing Clinical Education and Impact Education LLC. This activity is supported by an independent educational grant from Regeneron Pharmaceuticals Incorporated and Sanofi, and we would very much like to thank them for their support. At the conclusion of today's program, you will be able to complete an evaluation, which must be submitted to receive credit. Click the Complete Evaluation in the navigation within the activity, and once you complete your evaluation, you must then click Claim Credit to download your certificate, or for pharmacists participating today, submit your credit to the CPE monitor. Today's learning objective is to assess payer care management initiatives and other opportunities to improve treatment access and overall quality of care based on current evidence from clinical trials and treatment guidelines. I am joined today by Drs. Malin Hahn and Matthew Harmon. Dr. Hahn is Professor of Medicine and Chief of the Division of Pulmonary and Critical Care at the University of Michigan Health. And Dr. Harmon is the VP of Clinical Solutions at Employers Health. Welcome to you both.
Great to be here.
Yeah, happy to be here and part of the conversation.
Very much looking forward to it and appreciate both of you being here. So let's jump into it. And Dr. Hahn, I'll start with you. So my first question is, what are the current treatment guidelines for managing COPD? And how do these guidelines help clinicians determine the most appropriate treatment strategies for different patient populations? In other words, do the guidelines help us identify who the appropriate patient is for specific therapies?
Well, I would hope so. So I'm a member of a couple of the different groups that try to guide practicing clinicians on some of these issues. One of the groups that I'm affiliated with is GOLD, also known as the Global Initiative for Chronic Obstructive Lung Disease, and it's an international group that meets twice yearly to try to wade through the data and provide practical guidance for clinicians around the world. And we, do our best to try to help identify the right patients for the right treatments. And we're constantly updating this to reflect the latest evidence. I would say, right now, the baseline assessment tool that we use is called the GOLD ABE assessment tool. So that requires first that patients have an accurate diagnosis based on conducting spirometry. It's kind of shocking, actually, when you look at the data that only about a third of the patients in this country have had appropriate confirmative spirometry for those who carry a diagnosis of COPD. So I would say that's the first thing. We have kind of a lot of gross underutilization of spirometry in the United States, but it's actually, a painless and fairly easy to administer maneuver. So it's definitely something that that's, I would say, the first thing we need to focus on. And then after that, the severity of airflow obstruction is based on the lung function assessment in terms of FEV1% predicted, but the kind of treatment pathway is really guided by two things: how symptomatic is the patient, and how frequently are they exacerbating. So it's recommended that symptoms be assessed with either something called the MMRC dyspnea scale or the COPD assessment test, also known as the CAT score. MMRC is a little bit more focused on just dyspnea itself, whereas the CAT is a little bit more of a more global quality of life assessment. But regardless, if patients are, high symptoms based on a high MMRC score of 2 or more or CAT score of 10 or more, that would put them into a higher symptom group that GOLD would recommend be treated differently. So they've got kind of a low risk, low symptom group, which is what they term the A group. High symptoms, low risk of exacerbations is the B group. And then anyone that's had 2 or more exacerbations in the prior year or one severe one leading to hospitalization, that would bump you up regardless into the E group. And so I think, GOLD makes pretty clear what the initial treatment recommendations are. And essentially for the B and E group, it's dual bronchodilator therapy is initial therapy. But getting to your point about how we treat certain patients differently, in terms of initial management, if the patient has high blood eosinophils, like really high, or asthma overlap, I think a strong case can be made for adding inhaled corticosteroids right off the bat. But if you're trying to figure out how to manage patients down the line, let's say they come into your office and they're already on something, and you're trying to figure out, do I change this regimen and I need to intensify it, then that's where GOLD really at that point says focus on the treatment goal. Is it shortness of breath, in which case they recommend maxing out the bronchodilators. If the patient is still symptomatic, that's where you might want to think about switching inhaler devices or molecules, looking for other possible causes of shortness of breath. For frequent exacerbations, if that's really your treatment goal, then the general recommendation is maximize the dual bronchodilators if they're still having frequent flare-ups, and if the eosinophils are over 100, consider escalating further with inhaled steroids or other, sometimes also known as triple therapy. And then if they're having problems even further, there are opportunities for additional add-on medications that we can chat about. I think one of the things that's been really exciting for many of us in this space over the last year is that we've had a couple of new medications approved for COPD. So we can chat about that as well. But so I realize that's a bit of a mouthful, but that's sort of the general framework.
Thank you. And I will just say, I think payers, a lot of times, there's a misperception that we're trying to say no and we're trying to deny. And unfortunately, there are some players that have been in the public forum where maybe they've done some things inappropriately. But generally speaking, I think we're all on the same page in that we're trying to find the right drug for the right patient at the right time. And guidelines hopefully are helpful in that. But I'm going to use maybe a personal soapbox comment to bridge your great comments, Dr. Hahn, to a question I have for Dr. Harmon, and that is, I don't think generally speaking, unfortunately, guidelines translate well to payer policy and formularies. Because if you look at, say, the diabetes guidelines or HIV guidelines or even NCCN, they're not specific. They say you can use this class or this class or this class, let alone which drug is the most cost effective within a class. And if you look at HIV or NCCN, where there are 7 or 8 options that are considered preferred, that really doesn't help us. So I think what we're trying to find is help in building consensus to finding the right drug for the right patient. So with that, Dr. Harmon, my question to you is, now taking what Dr. Hahn has said from a clinical perspective, how do we value clinical guidelines to a payer for management of COPD? So how do guidelines influence coverage decisions, resource allocation, or the overall goal of optimizing both clinical and economic outcomes for our patients?
Yeah, excellent question, Jeff. And I agree with your comments. I think we'll try to talk about it in an ideal world because from a payer's perspective, the guidelines should serve as the foundation for that standardizing of care, and by ensuring that consistency in treatment decisions and ultimately optimizing both clinical outcomes and healthcare expenditures. So we could break it down to those 3 key areas where guidelines have the most impact that you mentioned. So coverage decisions, resource allocation, and cost containment. So with one of the biggest challenges payers facing is that balancing access to effective therapies with financial stability and sustainability. I really think guidelines help us define which treatments should be prioritized. Now, if the formulary does that or not, I think that's on that particular entity, and under what conditions should they be covered? So with the 2024 GOLD guidelines that were mentioned, that really introduce a more biomarker-driven approach to COPD therapy, particularly with the use of eosinophil counts to guide treatment selection. So patients with high eosinophil levels are more likely to benefit from those inhaled corticosteroids and biologics, and those with lower counts may be better managed with the LABA/LAMA combinations to avoid that unnecessary ICS exposure and associated risks that come with those. So payers use this evidence-based stratification to develop the PA criteria and the formulary tiers, again, ideally, that reflect the best practices, rather than taking a one-size-fits-all approach. We're now seeing more targeted coverage decisions based on patient-specific factors, which to me is very encouraging because that should also reduce inappropriate medication use. And I really feel like guidelines help streamline the approval process by providing clear, clinically justified criteria that support that timely access to high-value treatment. In terms of resource allocation, we really need to make sure those dollars are spent the most impactful way so we aren't denying an inordinate amount of patients that really would benefit from those medications. As we talked about in the other track on COPD, it is one of the most costly chronic conditions, exceeding over $50 billion in direct and indirect costs in the US alone, with most of those costs being due to hospitalizations, ER visits, and complications from the exacerbations. I quoted the stat last time of the average COPD related hospitalization range from $10,000 to $15,000, with readmissions adding even more financial strain. So if we adhere to the guidelines, payers can shift the focus towards being more proactive, preventive care, rather than those costly acute interventions. For high-risk patients, that early intervention with appropriate meds, such as the ICS LABA-LAMA combos or the biologics, can prevent some of those severe exacerbations and reduce those hospital admissions. One thing the guidelines also emphasize is the importance of that pulmonary rehabilitation, smoking cessation, self-management, education, so payers can use value-based incentive models to encourage providers to implement these strategies, which should also, help lead to better long-term disease control and that lower healthcare utilization. So I think a great example is the shift towards telehealth-based COPD management programs, since we know that not every patient has great access to a facility or a specialist in their area, particularly in rural areas and states. So guidelines can really support the remote monitoring for symptom management, so which payers can leverage to reduce those unnecessary ER visits. And by covering telehealth consultations and home spirometry, managed care organizations can improve the disease control without adding that excessive cost. And I think finally, the other major role the guidelines play is just helping payers implement those cost-effective strategies. So I think we should have more tiered formulary management, align the drug coverage with the gold recommended stepwise therapy to ensure that the patients start with the first line cost-effective treatments before escalating to higher cost products when appropriate. But I think we can use the guidelines to justify the use of PA criteria to ensure that those high cost therapies are only approved for the appropriate patients, like those with the frequent exacerbations or high eosinophil counts. Another, you can look at from a value-based contracting perspective, outcomes-based agreements with manufacturers to align with real-world treatment success. And I think there is some start and movement towards that. If there could be structures if the drug fails to reduce exacerbation rates in a pre-specified percentage, could be one avenue we tackle. And then ultimately trying to reduce those long-term oral corticosteroids, since they are associated with significant side effects like osteoporosis, diabetes, and the CV risk. So the GOLD guidelines really recommend the minimizing steroid use where possible, and so payers can use this as a basis for formulary adjustment. With all that, I think by following the strategies rooted in the guideline recommendations, we can hopefully ensure that COPD care remains both clinically effective and financially sustainable.
Thank you, Dr. Harmon, for those comments. And I will just add, I think we're in consensus that the guidelines are a great foundation and a starting point.
Mm-hmm.
But I think personally, just from my experience, if you go back, 10 or 15 years before the biologics, the guidelines still supported, to your point, monotherapy inhaler and kind of a step-up approach. And we saw a lot of the physicians going straight to dual inhalers at the beginning, right out of the chute, which makes sense actually. But I think it's an opportunity again where practice maybe doesn't follow guidelines, and now we have the biologics in there. And so it really is about, not to be repetitive, it's the right patient for the right drug at the right time. And so how can we build on these? And I think it would be awesome to have an opportunity where the clinicians and payers and different stakeholders were able to sit down and work on these guidelines, because we can learn from each other and make them more applicable to the real world.
Agreed.
Great comments, and guidelines are where we need to start. And when we are setting formularies, we want to make sure we're not going contrary to what the guidelines suggest. So I want to pivot a little bit and move off of guidelines more into the therapies, and I guess really how they fit within the guidelines, but clinical practice as well. So Dr. Hahn, I'm going to come back to you. And this is kind of a loaded question, a complicated question. And there's a lot of information here that we're going to unpack. But the question is, are there any pivotal trials or agents that are now available, and I would add, and which are soon to come in the future, for the treatment of COPD that have really changed the way you are selecting treatments? And what would you want our payer colleagues to be aware of?
Yeah, I have to admit, it's been a long time since we've had anything new to talk about with respect to therapies for COPD. So the fact that we actually have some things to discuss for me is very exciting for both patients and physicians. So maybe we should start with at least the two drugs that now do have FDA approval, with both of those approvals coming within the last year. I think that would be a good place to start. So one of those medications is called ensifentrine, and it is a novel PDE3, PDE4 inhibitor that is delivered via nebulized therapy. And there were two pivotal studies that helped to create the evidence basis for ensifentrine, the ENHANCE-1 and the ENHANCE-2 studies. The drug got its approval basis from the FDA based on FEV1 and an improvement in lung function as the primary endpoint. Key secondary endpoints in the study included symptoms as well as exacerbations. Now, one of the sort of surprise findings was that in a patient population that was not necessarily enriched for exacerbation patients, they actually managed to show a reduction in exacerbation. So they showed improvements in lung function, improvements in symptoms, and a reduction in exacerbations. What I will say is this: it's a little bit challenging because of the study design for all of us to interpret where to put this medication, because not all of the patients were necessarily on triple therapy. But if the goal is to improve shortness of breath, which I think this medication does, then the maximal treatment, if you were to go based on GOLD for that subgroup, would be dual bronchodilators. And that is why GOLD has put ensifentrine on that part of the pathway. So if you have a patient with persistent dyspnea, they're still having shortness of breath despite dual bronchodilator therapy, consider this for an add-on. I can tell you anecdotally, since it's been out, some patients, I've actually been surprised. There's some patients who actually do seem to have a huge symptom benefit, some more modest, but there are a few that do seem to be kind of what I'll call a super responder. And I wish I could tell you which those patients are going to be ahead of time, and I can't tell you. But I would say, again, based on the data and what I'm seeing in my own practice, that there definitely are a subset of patients that may benefit. The drug does not currently have an FDA label indication for exacerbation reduction. And I think one of the challenges from a guideline perspective in terms of where to put it is, again, a lot of the patients weren't already on triple therapy. So it's was hard for us to figure out how would you even comment on that without more evidence for exacerbation reduction specifically. So that's kind of how I'm, thinking about it right now. But I will say, I think it's definitely helping some patients for sure. And it's exciting to have a new treatment option. And I have no idea if they're going to go on and pursue additional studies looking more specifically at the exacerbation reduction angle or not. But definitely, I think there is lung function and symptom improvement for, definitely some patients. The other medication that was FDA approved in the last year is a drug called dupilumab. So the design of the dupilumab studies was definitely different. So dupilumab targets type 2 inflammation, the IL-4 and IL-13 pathway. And traditionally, we always thought about this as being more relevant for asthma. We didn't really realize that it was relevant for a subset of patients. But it is clear, I think, based on a lot of studies now, that there really is an element of type 2 inflammation for some patients with COPD. And so the two pivotal phase 3 studies that were done for dupilumab were the BOREAS and the NOTUS studies. They both were 52-week studies. They looked at dupilumab compared to placebo. So it's important to think about the patients that were included in the study. First of all, all the patients had to have eosinophil counts of 300 or more. And second, all of these patients were on triple inhaled therapy. So that's the patient group that it was studied in, and that is the patient group where GOLD recommends, and that is the patient group where I'm thinking about it. They were able to show significant reductions in annual rate of exacerbations in both the Boreas and the NOTUS studies. They also showed things like improvements in symptoms and quality of life metrics as well. I will say it's important to remember, though, that dupilumab was already approved for asthma. So at least in my mind, that means there are asthma patients that would benefit. There are COPD patients who would benefit with the eosinophil criteria being different, 150 for asthma, 300 for COPD. The kinds of patients that were not specifically included in either of these studies, but I think also benefit, are patients who have asthma COPD overlap. And this is where it gets a little bit messier, I think, for everybody. But I think the data would support it helps these patients as well. So for me, the patients I would probably choose for ensifentrine are a little different than the patients I would choose for dupilumab, with one probably targeting more dyspnea, for the other one targeting more exacerbations. And the subgroups are different too, with dupilumab clearly being beneficial in the patients that have type 2 inflammation. Now, if we think about some of the medications that are sort of just on the cusp, there's additional medications looking at type 2 inflammation and COPD. There are some other pathways that are being investigated, the IL-33 pathway in particular, I'm actually most excited about. So that is not going to be the high eosinophil patients. And those studies are going to just start to, I think, read out this year. So I think in the next few years, we will have additional medications, I'm hoping, to give these patients. And, hopefully, with careful study designs, will, as clinicians and individuals who make the guidelines, be able to appropriately figure out how to place them. But we really, again, depend on the kinds of patients that were included in these trials to be able to make those decisions.
That is great information. Thank you. And that's a great foundation for now moving into really the primary objective of this program, and that is talk about barriers and how we can collaborate. So to come right back to you, Dr. Hahn, from the clinical perspective, what are the primary barriers to treatment for COPD that patients or providers face?
There are a lot of barriers. I will say, we chatted a little bit at the beginning of the talk about the importance of telehealth for these patients. I actually grew up in Idaho and trained at the University of Washington, where we had a lot of patients in rural communities. And you would think in Michigan, where I live now, it wouldn't be as much of an issue, but it still really is. When we think about the COPD patient population, some of them are not comfortable driving themselves. And, trying to get in to see specialists can be challenging, particularly in the winter here in Michigan. So I actually just had a virtual clinic this morning with a COPD patient, and she was very grateful that she could continue to, interact with me, get her medications tweaked, et cetera, based on that virtual interaction. And we have a funding cliff for that coming up with respect to Medicare. So I think, thinking about how COPD patients just access care in general. I know we've got a specialist shortage, and I actually chatted with some primary care physicians just last week, and despite all of our efforts, I think as specialists, to try to make the guidelines as clear as possible, it is clear we need to continue to work on that, because I think as the treatment landscape gets more complicated, it's getting more confusing for clinicians. So, but we've got to focus on making sure patients have access to spirometry and correct diagnoses. I wish places like CVS actually would figure out how to not just do blood pressure, but figure out how we can get more spirometry at the local level. I think we need to expand telehealth. Figuring out patient adherence and inhaler technique is also a challenge. I will say, particularly with virtual visits, because that gets a little harder for me. The good news is that local pharmacies, this is something that they can actually help with. I think that's underutilized, and we sometimes forget that. that if a patient is going and picking up their prescription from a Walmart or a CVS or whatever, there are pharmacists there who can actually go over and review inhaler technique with them. I think another challenge we have is access to pulmonary rehabilitation. And this has just, again, been sort of the roller coaster of coverage for the last few years. So when they finally made a CMS determination to cover pulmonary rehab for COPD, they included in that a provision that you had to have an on-site provider. And so this actually closed a lot of the more rurally and community located pulmonary rehab facilities. So I still have patients that if to get to rehab would be a 50-mile drive, which is not practical if you're asking them to go several times a week. So during the pandemic, some of those restrictions were lifted and we saw an increase in virtual rehab programs, but the coverage for that was pulled back again. And so, we're trying to kind of work through what some piecemeal solutions could look like, but that's just, another thing that we know definitely benefits patients and it's just been challenging again to provide access for. So I think, those, it was kind of a lot, but there is a lot of challenge we have in trying to provide, good care and good coordinated care for these patients.
Oh, you're right. There are a lot of barriers, but we need to discuss those and identify those before we can start to address those. So I think those comments are great. And that is a great provider perspective. I've been saying for a long time that we're heading towards an accessibility and affordability cliff.
Yeah.
And if we don't better collaborate, then this is going to be a problem for our patients.
Yep.
And you touched on a lot of good things, and it goes back to what we were talking about earlier too, is that there's a challenge between building a formulary, but also addressing things like population health and social determinants of health, because formularies are population tools. And so we need to identify and acknowledge that there are a lot of other barriers that are more patient specific. And then the challenge is, how do we address those from a payer perspective? So I appreciate your comments. And so I'm going to ask you now, Dr. Harmon, really two questions. We've heard the provider perspective, but do you have anything to add from a payer perspective? And then the second question is, after that, how can managed care organizations address these barriers to improve access to effective care?
Sure. Yeah, I think there's a lot of overlap there with what Dr. Hahn was mentioning. So it really is a critical issue because, even the best treatment options are ineffective if patients can't access or adhere to them. So I think, there's several key strategies payers can adopt to address those common barriers like medication adherence, delayed diagnosis, and the limited access to, specialty care that we've kind of hit on. So really that focus on enhancing that patient education and medication adherence support. So we know that the treatment regimens for COPD are complex, and so incorrect inhaler use, is a common problem. And so we can try to support adherence by covering pharmacist-led counseling, some of the remote monitoring programs. Let's bring back some of the telehealth coverage. And since if it was working for those patients, that I don't want them to have to drive 50 miles and if they're not going to drive that, then they're not going to get the right care, and we're just ultimately just delaying care and promoting poor outcomes. So I think we could leverage more of those telehealth and digital health solutions, the digital inhaler training tools. I think we could really help detect exacerbations early. Those remote patient monitoring that we're seeing in other conditions like diabetes are helping improve outcomes there. I think we should make sure that we're not just that we are using it for other conditions. So I think payers can help encourage the use of some of the mobile health platforms to track usage and lung function trends. And I totally agree. We should try to expand the access to pulmonary rehab since it is underutilized, even though we have the data that shows it improves quality of life and reduces exacerbations. So let's think about how can we maybe reduce copays or have value-based reimbursement models that include rehab as part of that COPD care. And I think also the case management care coordination perspective, we know that COPD patients generally have comorbid conditions that could make coordination across specialties essential. So can we have access to case management programs that integrate pulmonologists, primary care, and pharmacists to try to ensure a seamless approach to care? So as many barriers we can remove, I think the better to improve the patient outcomes, but making sure that we're doing the ones that have the evidence behind it to reduce the avoidable healthcare costs. And I think to your second question on, what can we do? I think payers must take a strategic evidence-based approach to benefit design. We want to ensure that, the cost-effective access to treatment while maintaining, sustainability. So really having that, the evidence-based formulary management, I think we could have tiered formularies that align with the guidelines that we mentioned to prioritize those high-value treatments. So I think, steps therapy ensures the patients try the standard ICS, LAMA combos before, moving to biologics, unless the biomarker evidence supports earlier biologic use. So I think making sure that testing is incorporated into the PA criteria will be critical. I think we've talked a little bit about the value-based contracts and outcomes-based pricing. So it feels like COPD is a condition where we can have these agreements with manufacturers to try, tie that drug reimbursement to real-world performance. Linking it back to exacerbation reduction rates, for example. I believe there are some instances out there with payers and manufacturers, so worth exploring there. And I think from just the cost-effective use of biologics, that's those targeting the biologic therapy to the COPD patients with those eosinophil levels will ensure that those treatments are used in the right population. So can we have documentation of the levels in our criteria before a biologic approval, since that is the whole thing. A lot we see in PA criteria. Dr. Hahn, interested to hear your thoughts on that attestation versus documentation. Sometimes we see there's a willingness to check a box, but even though the patient may not have tried things. So I know there's been a larger push in the payer community to require documentation when it makes sense. But I know that can create some bigger headaches on physicians, and ideally we use technology that can incorporate things from electronic health records to optimize that. But still think that the technology is there, but I don't know how adopted it is across the board. And then I think from an integrated care model perspective, you have coordinating the COPD management across all the different spectrums, from primary care to pulmonologists, pharmacists that, like Dr. Hahn mentioned. I think we should try to utilize them more often in care, and as well as the rehab programs to improve adherence and reduce hospitalizations. I think there are a variety of different strategies out there to achieve a win-win, improving that patient access to effective therapies while hopefully maintaining some financial sustainability.
Thank you, Dr. Harmon. Great comments. And maybe I could just, from my perspective, build on some of those.
Please.
The formulary comments were great. We need to focus on value and comparative cost effectiveness, not necessarily rebates and things like that, but we need to make sure that the prior authorizations are appropriate. The value-based contracts are interesting. We've had those for many years now, but they're largely ineffectual in my opinion. I don't know if you disagree with that. If they're tied to utilization, they're fine, but when we get into actual outcomes, due to lack of data or subjective outcomes or caveats, they're really actually hard to implement. So it's kind of the holy grail if we could actually get to a shared risk model and have pharma providers and payers involved in that would be amazing. I think it's just extremely difficult to do. And I like the comments around the integrated care models and coordination there. And there are models out there that I've seen that, and this is maybe the bridge between a population formulary tool and how we get into dealing with social determinants of health and inequities and things like that, is more through the care management side. But I've seen really good models that are proactive and not just really do the traditional disease management, but look at gaps in care and focus on patients who are maybe not adherent or who are using a lot of resources and get more involved with them. And I've actually seen a really cool thing where people have built in social work as part of that as well. And that's something that's not necessarily always on our list, but just community resources and having a social worker be able to tie in and educate patients about what's out there helps within education and any number of other things and helps them just follow up more appropriately. So great comments. Sorry for that little sidebar. But we're nearing the end, and so I want to ask each of you one last question, and I'll start with you, Dr. Hahn. And that is, based on what Dr. Harmon and I have just talked about what payers are doing, to support our members. How do you think multidisciplinary care teams contribute to the effective management of COPD, and how would you like payers to work better with you?
They're all great questions. You know, we had a really solid multidisciplinary kind of clinic for COPD before the pandemic, where I had nursing, respiratory therapy, social work, nutrition, etc. The problem is it's very difficult to figure out how to fund those individuals in the context of an outpatient clinic. They provide a lot of value, but don't bill directly. And then the pandemic hit and everything in person kind of got dismantled. And we actually never were able to completely pull together the resources again, with the health system just being under more financial duress afterwards. So if there were a way to better kind of solve and provide that multidisciplinary care and figure out actually how to pay for it, that could be hugely beneficial. I will also say, as just an aside, I am also really excited about certain AI-driven solutions that could make lives of physicians and patients better, not necessarily replacing doctors, but by even summarizing data, trying to highlight important things or changes to the medical record that could help us make decisions faster, possibly helping with some of this paperwork burden. The prior auths, I will say, do take I just started one this morning, do take a reasonable amount of time. I also think there's the potential, again, I realize I'm going off topic here a little bit, but just in closing thoughts, I think there's also a lot of potential for AI in terms of patient navigation. There's so much that could be done there in terms of, reminding them what needs to be done when, helping them navigate appointments, reminders for vaccines, et cetera, et cetera. So I know it's going to, we're just sort of at the forefront of the AI revolution, but from what I've seen so far, I'm actually very optimistic about how those kinds of solutions potentially could be helpful in the future.
It's a very relevant comment. Payers are pretty far down the path of using AI and PAs, to your point, but there's so much more we can do, and it's all about big data. So having access to more information and be able to synthesize that and make things more efficient, because we acknowledge the barrier that PAs have on providers, but there is so much more that we can do to break down some of those barriers. So I think it was a timely comment, and I appreciate that. And to your other comment, around who pays for this and what's going on, is end of the day, it falls on the health plan and the employer, but they're already paying for these things right now. And like I said, there are some great programs out there. The challenge is you as a provider are communicating with the patient, us as payers are communicating with the patient, maybe the SP is communicating. So the point of this, if we don't do this in a better way and more collaboratively, then rather than helping the patient, it actually can make it more frustrating for the patient, where they're getting multiple calls and maybe contradictory information. So it's super important, that collaboration. So thank you, Dr. Hahn. So Dr. Harmon, my last question for you is, what role do you see for managed care organizations in facilitating and supporting this multidisciplinary care in COPD?
Right. I mean, I think our discussion today really highlights that multidisciplinary care is essential for COPD. It's a complex chronic disease that's influenced by multiple factors. So payers can really play a central role in promoting integrated care models that improve the patient outcomes. So we think about some of the PCMHs, those patient-centered medical homes and integrated care pathways that are out there. So I think these models help promote the collaboration between the pulmonologists, primary care physicians, the pharmacists, and those rehab specialists. And so payers can incentivize providers to participate in PCMHs, through alternative payment models potentially. Could be one way. I like using some data analytics to identify those gaps in care that you mentioned, Jeff, earlier, so we can really dig into the claims data to track exacerbation trends and flag those high-risk patients for targeted intervention, or sending a specialist or having a pharmacist contact those high-risk members and really get involved with their care to see what can we do to get them on the right track. It seems to be a worthwhile use of time and resources. So, and I think as we talked a little bit about, it seems like there were investments in telehealth and coverage there during the pandemic, and removing those, I think, is short-sighted. So can we get back investing some the smart inhalers, the telemedicine to help patients stay connected with their care teams to reduce some of those preventable exacerbations and really adjust things based on those particular patient needs. I think by proactively supporting that multidisciplinary care, us managed care organizations can drive better outcomes and lower healthcare costs and overall improve the COPD treatment experience for the patients involved.
Thank you. I have really enjoyed the conversation today, and you've brought up a lot of great points. So I would like to thank both of you, Dr. Hahn and Dr. Harmon, for all the comments today. And at this time, we would like to address some of the audience questions that have come in.
It's like a lot of the questions that have come in kind of fall into two buckets. So I'm going to start with you, Dr. Hahn, and a couple questions here around the cost of the biologics. First is, do you think that most providers are aware of the cost of the biologics? And then secondly, given that, how would you recommend that providers and payers collaborate around the appropriate use of these agents? I know we've kind of talked about that in the presentation, but maybe you could summarize that. So again, do you think people are aware of the cost of the biologics? And then how can we collaborate to ensure that they're used appropriately?
I don't know that providers know the exact dollar value, but I think they're generally aware that they're more expensive. Although we have other treatments in COPD, including a recently approved nebulized medication for COPD that are also expensive. And so I think providers are well aware that when you've got new drugs, even honestly new inhalers, when they come to the market, we know we're going to have difficulty prescribing them. So given just the number of prior auths that we're forced to process, I don't think the cost of medications are lost on physicians at all. And I think we think, very hard about, trying to do the best thing for patients. I think you have to realize from a provider perspective, trying to get patients switched over to new medications is usually driven out of patient desperation. That's just how awful many of these patients feel with severe dyspnea and frequent exacerbations, and they'll hop from doctor to doctor looking for help. We've had so few new therapies in this space for so long that, I think it's just important to realize that patients are desperate and providers are desperate. So what could be helpful? I think sometimes it's not 100% clear to physicians, to be honest, what documentation is being looked for, what needs to be tried before they can go ahead and try to process something. And you only figure that out on the back end or after you've processed a few. And then, of course, every insurance is a little bit different. So if there was some way to get that clarity to physicians before they start the process, it would be really helpful. And a lot of times that's just information we don't have on the front end when we're trying to, get a patient started on a new medication. So I don't know if there's a way to increase the transparency, but if physicians had a better understanding of what's being looked for, I think it could potentially reduce some of the paperwork burden.
Awesome. And I'm going to summarize here in a minute to conclude the best practices. So I'm going to go through that, and if based on what you just said, if we're off, let us know. But I think we're going to summarize it here, hopefully well in a minute. And then the other bucket of questions were around some of these hot topics like social determinants of health and health inequalities and disparities. And I know, Dr. Harmon, you spoke about a lot of things we can do, like telemedicine and other things, but maybe you could kind of summarize that. What is the impact of disparities in COPD? Because I think the perception is that they're higher in COPD than a lot of other diseases. So is that accurate? And then again, can you kind of summarize very quickly any ideas you have to address those things?
Sure. Yes, I think that is accurate. So it's a critical question that we need to really be talking about, because can't really improve outcomes without addressing the social and economic factors that drive the disparities in care. So we talked a little bit about just the access and affordability of medications. Just lower income patients are more likely to skip refills or delay care, end up in the ER because they couldn't afford their inhaler. Some of the geographical and rural access issues. So, the nearest specialty providers hours away, you can't be surprised when these patients have worse outcomes. So I think one of the biggest takeaways from me from doing these talks is how we need to really expand telehealth and some of the pulmonary rehab facilities and access to those, and not constrict it as has been the case. So when we saw positive results from the pandemic and now we're taking it away, that to me, that doesn't make as much sense. And then going from the racial ethnic disparities, we see even when diagnosed, there's a treatment gap. Prescribing patterns show that patients are less likely to receive the therapy they need despite similar disease severity. So what can we do? I think really, we already use predictive analytics to identify high-risk patients based on claims and medication history. Can we layer in some social determinants? Can we, as health plans, incorporate zip code level data on air quality, income level, and access to care to better, identify those at-risk patients, and then potentially address some of those medication access issues. If cost truly is a barrier, let's adjust the formularies accordingly, or trying to get $0 coverage for those patients that would benefit to them. And find other ways that we can invest in some sort of community health partnerships, working with local organizations to fund better air pollution programs, that sort of thing. So, but that's that next level. But to me, I think there's a variety of things that we can do, since at the end of the day, it's just not about coverage policies. It's about looking at COPD management through a wider lens. If we don't address the financial, geographic, and systemic barriers that are keeping patients from getting care, we'll just always be playing catch up. And so I think we have the opportunity to lead the charge by integrating social determinants of health data, improving access, and working with providers to close those gaps.
So thank you. So I'm going to conclude by reading our summary of best practices in COPD management and summarizing, and then just will ask you, Dr. Hahn and Dr. Harmon, if you have any other comments based on this summary, and then we will wrap up. So smoking cessation is the most effective intervention for slowing COPD progression, and that should be part of any communication we have with patients if they're smoking, that we should do anything we can to help them stop smoking. Bronchodilators, such as the LAMAs and LABAs, are used for symptomatic relief and lung function improvement. ICSs are added for patients with high eosinophils or frequent exacerbations. And then triple therapy, so using all three, LAMA, LABA, ICS, should be used or could be used in patients with severe disease or patients who are still having exacerbations despite being on the other therapies. And then if patients are still having exacerbations or they have type 2 inflammation, then we should consider adding, and it's not a replacement, but it's adding a biologic therapy. And then other things we do around drug therapy is pulmonary rehabilitation. That improves dyspnea, exercise tolerance, and quality of life. And then we should be supporting multidisciplinary care delivery, remote monitoring, and telehealth for symptom tracking, and investigate value-based care models that incentivize guideline-directed management. So again, Dr. Harmon, Dr. Hahn, any comments? Is this a fair summary?
I think this is a good summary of, I think where we're at right now. I think it's I think with each of these, elements, while they're great guidelines, we still struggle a little bit due to various factors with implementation, whether it's physicians who aren't completely aware of maybe the latest recommendations, whether it's insurance that doesn't necessarily, cover, although I will say, for instance, the coverage, at least in my personal experience for triple therapy for patients for COPD, continues to get better and better. Another areas, that we touched on and we struggle a little bit with is multidisciplinary care. And then there's the whole topic of pulmonary rehabilitation, where we've got a lot of, brick and mortar centers, but a lot of patients who can't get to brick and mortar centers. And the virtual care that was covered under Medicare was pulled. So I think this does represent a good summary, but I think we still have work to do.
Fair.
Yeah, I would agree with Dr. Hahn. It is a solid summary, but I think we can't just think about COPD in just from a medication standpoint, as sometimes like to do. And that's why it's nice to see some of these later bullet points, especially in the multidisciplinary care piece, since it's not a condition that plays well in a fragmented care model. And I think as long as we could keep shifting towards being more proactive in the care, that's, I think, some of the strategies we discussed today, from remote monitoring, telehealth, and potentially value-based reimbursement. I think we'll really see some improvement. If we think of it only as a hospital first, medication only mindset, we're never really going to bend that cost curve. So how do we start rewarding preventive care, early intervention, and smarter therapy selection? We can drive better outcomes. But hopefully we've given some good tidbits that people can take back to their jobs, and would love to hear feedback on any gaps that we may have missed in discussing the gaps in COPD care.
Well, we did have a comment from one of our participants today that said, she said that paramedicine programs work great in this space, assessing the home environment, inhaler technique, access to care, transportation issues, et cetera. So it reinforces there's an opportunity here. We're doing things, but there's still room for improvement. But all of these things are things that we need to continue to reinforce with our patients and our members on an ongoing basis. So again, transportation, inhaler technique, all of these things. So thank you for that comment. So at this time, we will conclude the webcast. I would like to thank our faculty, Dr. Hahn, Dr. Harmon, for the great presentations and insightful discussion. Once again, I would like to thank Regeneron Pharmaceuticals Incorporated and Sanofi for their support of this educational activity. To claim credit for this activity, please click the complete evaluation link in the activity. And then once the evaluation is complete and submitted, you will be able to download or select the type of credit you require. And you must claim your credit to receive your certificate. And then for pharmacists to submit to the CPE monitor. And then finally, for the full CE series on type 2 inflammation, be sure to visit impactedu.net. And the exact address is here. It's www.impactedu.net/T2-inflammation. And you'll find their CE podcasts and infographics on EOE, atopic dermatitis, asthma, and COPD. So this concludes today's webcast. I hope you enjoyed it, and I hope you have a great rest of your day. Thank you.